Good morning. Welcome for the Regional Oley Foundation meeting, the mini meeting that was being performed completely virtually this year. And I thank you very much for your attention and interest in intestinal rehabilitation, the short story. I'm going to talk a little bit today about some information that's not all completely new, but I think that many people are unaware of the options for therapy, at least from a surgical standpoint. And so I will start kind of back at the very beginning. Intestinal failure by definition means that there's not enough gut or a functioning gut mass that's reduced below the amount necessary for digestion and absorption of adequate nutrition. One of the alternative definitions is portrayed here in this cartoon, where you can see from one end of the bowel to the other with the scope, and that would be short bowel syndrome. When we look at the causes of intestinal failure, of course, short bowel syndrome is the most common. In children, these are often the disasters that lead to massive resection in infancy. And in adults, similarly, it's usually due to resection, either from iatrogenic injuries, multiple bowel obstructions requiring resection, or mesenteric ischemia. But there are also a host of functional disorders which can cause poor function of the bowel, even in the absence of resection. What we do know is that things have not changed very much over time, and that survival on parenteral nutrition is relatively poor, with at least 10% mortality in the first year and as much as 40% mortality by the time 5 years has passed. This was verified somewhat in a North American large registry summary of short bowel syndrome and motility disorders, with, again, between 87 and 94% 1 year survival and diminished to 70 to 80% at 4 years. A more recent study from approximately 50 centers across the world, including over 2,000 patients, showed that at 1 year, about 80% remained still TPN dependent. Those that weaned were a minority, only about 14% in this large multi-center series, and approximately 7% died from complications. Interestingly, of those that weaned, spontaneous adaptation accounted for only about 50%, and both non-transplant surgeries and intestinal transplant really were responsible for the rest of the weaning. And so this is what we will be concentrating on today. This is just showing that with parenteral nutrition, there is some improvement over time, somewhat dependent on the amount of volume required in the HPN, and that there is an increased mortality over time. And this is higher in patients that require calories than those that just require IV fluids. When looking in a multivariate assessment for risks for weaning or death, when we look at weaning, we know that the amount of TPN, the age of the recipient, and the time on parenteral nutrition greater than 1 year all portend a poor outcome with weaning. But a high BMI actually is beneficial in this group as a positive predictor. When we look at mortality, again, age has a worse outcome in terms of mortality. Those that are malnourished have worse outcomes. And those with angiogynostomies or very short segments of bowel, those that have fistulas, dysmotility, obstruction, and mesenteric ischemia as their underlying diagnosis all have worse outcome. But those that are treated in centers with a higher volume of experience actually have less death in their patients that they care for than others. We know that cholestasis is important, and the study from the Michigan group shows that cholestasis impairs long-term survival, and that in a multivariate analysis that cholestasis was actually the highest risk at a risk ratio of 20 for patient's mortality risk factors, and much higher than just the bowel length, the loss of the ileocecal valve, or whether or not colon remained. So what are our potential therapies for patients with intestinal failure? Well, we're not going to talk today, here by me anyway, about medical therapies, although there are a number of really good medical therapies that have been described, some that are more recent in FDA approval and some that are still in investigational modes. But we will talk a bit about non-transplant surgical therapies and specifically the lengthening surgery. And then we'll also talk about intestinal transplant in terms of isolated transplant or combined liver small bowel. We won't be covering multivisceral transplant or isolated liver transplant in today's talk. So when we see a patient who has short bowel syndrome and we're going to do a surgical evaluation to determine if intestinal rehabilitation or transplant is an option, we want to answer a number of questions. We want to know whether or not the intestinal failure is permanent, because if it's not permanent, then perhaps just waiting and using our medical therapy might be the best option. We also want to understand what complications the patient is experiencing, because we want to know if they are severe or life-threatening or minor and easily managed, whether or not they're reversible, and whether they're treatable with things other than surgical intervention. So one of the things that we look at is the length of the remnant intestine, and this would be an example of a intestinal rehab patient or transplant evaluation where there really is no hope for any weaning long-term, because their stomach empties directly into the duodenum, which is attached to the sigmoid colon. When we look at complications, we differentiate those related to the short bowel syndrome itself or the intestinal failure from those related to TPN. And many of those related to the short bowel syndrome can be managed with medical therapies, including those that decrease motility or improve absorption and nutritional supplementation. But those that are related to the TPN can be life-threatening if the TPN cannot be discontinued. And so weaning of parenteral nutrition is really the key to determining whether or not we should do a non-transplant surgery or transplant in this population. If they have things like recurrent line sepsis, especially if it's fungal in nature, if they have loss of venous access and no hope for administering TPN, or if they have liver dysfunction. So this is an example of a patient that might have need for transplant because they cannot have TPN administered if all of the veins in the neck and the chest, the superior vena cava, are all thrombosed. This is what the veins should look like in a normal venogram. Furthermore, if they have jaundice, it's important to determine whether or not that is simple cholestasis or whether there's full-blown cirrhosis, which would be irreversible and might require a liver transplant rather than either an isolated bowel or a non-transplant surgical therapy. So I have several case examples to help illustrate scenarios that each of the different alternatives for surgical intervention might be indicated, and I have altered a bit of the details to protect identities, but the substance of the decision-making is unchanged from the actual cases. So in the first case scenario, I'm describing a 24-year-old male that has approximately 80 centimeters of remnant jejunum after traumatic mesenteric injury required an extensive dissection or resection. The bowel is in continuity in this patient, and the stool output is relatively high at approximately 2.5 liters per day. But despite this, the patient was able to take approximately 60% of their calories enterally and had maintenance of weight. Unfortunately, the patient had had multiple episodes of hospitalization for dehydration and electrolyte abnormalities, as well as renal dysfunction over the year prior to evaluation. We decided to have a full evaluation, including a small bowel series and upper endoscopy to look for sources for the high output. We did labs to evaluate the electrolytes, renal function, and liver function at the baseline. And we did several medical therapeutic trials, including treatment of bacterial overgrowth, probiotics, motility agents, such as Imodium. And we also had the patient on a GLP-2 analog for some time without improvement. We therefore elected to do non-transplant surgery when the small bowel series showed dilated small bowel greater than 4 centimeters in diameter. And this I'll describe here. So probably the most common non-transplant surgeries after closure of fistula and ostomies would be a lengthening procedure. And this is a fairly unique surgery that is not widely performed by non-specialists in intestinal failure therapy. So the oldest and probably highest volume of surgeries over the many years, more than 30 years now, is the Bianchi lengthening. And this one takes advantage of the fact that there are 2 leaves to the small intestine mesentery, and you can actually create a tunnel within the mesentery between the 2 leaves that allow the vessels to go to each side of the dilated small bowel. And once you've created this tunnel, you can actually divide the small bowel into 2 more normal sized loops of bowel compared to the dilated bowel that we started with. And as you progress through the dilated length, you get 2 parallel loops of more normal sized intestine. And once all of the staples have been fired and the bowel has been transected, then there's the ability to put those parallel loops end to end to essentially double the length of the intestine and then decrease it to a more normal caliber. And this is the Bianchi or longitudinal lengthening. The other option is called step lengthening, and this is a serial transverse enteroplasty. And rather than cutting the bowel longitudinally, it takes advantage of stapling devices to actually divide the bowel, usually from mesenteric to antimesenteric in an alternating fashion, leaving what would be a normal caliber of bowel out of the staple line. Once the staples have been placed by moving, again, a normal caliber of bowel distance from the staple line. So in children, this may be as small as 1 centimeter between staple lines, but in adults, usually closer to 2 centimeters. Once all the staples are fired and all of these staple lines open up, you end up with the zigzag pattern, which is a more normal, probably 2 centimeter caliber in adults. And you increase the length of the bowel by each of these V-shaped segments to increase absorptive capacity across the intestine. The group from Toronto, Canada looked at improved function of the bowel in a series of 7 patients that they did step enteroplasties on, and they noted that before the step enteroplasty, for example, stool output was 8 plus or minus 4 stools per day, and this decreased to a more normal 1 or 2 stools after lengthening. They also noted that absorption was clearly improved with tests such as citrulline and D-xylose, and that fecal fat was decreased, suggesting improved fat absorption as well. And in many of these patients, they came off of their parenteral nutrition, whereas 71% of the calories prior to the step had been provided by parenteral nutrition, and on average 12% of calories at the end of 1 year. I had also published on this in adult patients, and we had a series of 14 adult patients that underwent either the Bianchi or the step lengthening. And again, I had found, just as in children, there was no difference in outcomes between the Bianchi or the step, and that approximately 60% were able to wean from parenteral nutrition after a lengthening procedure. So in the second case, this patient is a 39-year-old who had a mesenteric ischemic episode at the age of 30, had been PN dependent for 2 years, with only 40 centimeters of remnant small bowel, also in continuity. The patient had experienced life-threatening septic events with fungal organisms, leading to ICU admission and vasopressor support, and also had longstanding evidence of liver injury with a total bilirubin of 4 at the time of his evaluation, splenomegaly, and decreased platelet count. So we did evaluate the length of small bowel, and although this is not the actual image from this patient due to lack of consent, the patient did not appear to have enough bowel remnant length to perform any type of lengthening procedure, nor was the bowel dilated. In addition, there was some bridging fibrosis, although not full-blown cirrhosis, and it was felt that the liver biopsy was consistent with an irreversible injury to the native liver. So when we looked at what procedures, we felt that transplant was the best option in this patient, and that isolated bowel transplant would leave the patient at risk for complications from end-stage liver disease, and therefore a combined liver, small bowel, pancreas transplant was chosen. This is a schematic of what is involved with the combined transplant. The liver is resected from the donor with the retrohepatic vena cava intact. We divide it above and below the liver. We leave the entire hilum, including the portal vein, hepatic artery, and bile duct, completely intact without dissection between the liver and the duodenum. We leave the pancreas attached to the duodenum, and we take the entire length of the jejunum and ileum. And in probably 60%, we also include a portion of the right colon over the last 5 years or so. In a small percentage, if we have to resect the native stomach or a good portion of it, we may also include the stomach. And most patients or most centers refer to this as a multivisceral graft, when in fact there's not much difference between the liver, small bowel, pancreas. Having said that, in this patient, we left the stomach intact and we were able to perform a proximal jejunostomy. And we did include a portion of the colon, and so rather than an end ileostomy, we brought up a loop and connected the donor and recipient colon. This is an example of the aortic conduit that we bring with the liver allograft, the liver small bowel allograft. We take the entire donor thoracic aorta with the celiac trunk as well as the superior mesenteric artery. We divide the aorta from the donor just below the superior mesenteric artery and above the renal arteries, and we just oversew this end. We ligate all of the intercostal branches along the posterior aspect. And then we divide the thoracic aorta and implant the longer segment on the recipient's aorta, and then just reconnect this so that we're not deep into the abdominal cavity when we reconnect our vessels. The only other vascular anastomosis then is to replace the retrohepatic cava because we leave all of the hilar structures intact. Once we place the graft in and we've attached the cava above and below and the aorta is described and revascularized, this is the appearance with a very normal liver, normal looking small bowel with good peristalsis. And then we just need to connect the proximal remnant small bowel to the donor jejunum and the distal intestine to the remnant native colon. In the final case scenario, there was a 43-year-old female with short bowel syndrome secondary to mesenteric ischemia after laparoscopic cholecystectomy. The patient had been PN dependent for 7 years and had been relatively stable, although they were continued on long-term anticoagulation due to an episode of DVT prior to this ischemic event, and then of course the mesenteric ischemia. Patient had suffered from multiple line infections, although these did not require ICU admission. But at the time of evaluation, the patient had swelling of the left arm, which is the same side as the Hickman catheter was placed, as well as around the patient's eyes. And the liver function continued to be normal with normal coagulation tests. Again, these are not from this particular recipient. However, they demonstrate the types of things that we were looking for. On liver biopsy, we found some evidence of cholestasis, but no evidence of any fibrosis, either periportal or bridging, and certainly no cirrhosis. And on imaging, we found superior vena caval syndrome with collateral formation around all of the major vessels in the head and neck. We therefore thought that an isolated small bowel transplant would be the best option, as this was a younger patient who had potential for long-term survival, but would have a difficulty getting IV nutrition due to lack of venous access, and had a preserved liver function, so did not require a liver transplant. This is an example of how we do this, a schematic. We keep the native stomach, duodenum, and pancreas when we do an isolated small bowel, and take the entire jejunum and ileum based on the superior mesenteric artery and vein. Again, we can include a portion of the colon as part of the graft. The Venous outflow, well, the inflow and outflow are the superior mesenteric artery and superior mesenteric vein. And we can connect the superior mesenteric vein either to the native superior mesenteric vein at the site of bowel resection, if it's easy to identify, or to the portal vein occasionally with the jump graft, although this is rarely done, and more commonly to the inferior vena cava. And really all of these serve as reasonable outflow, provided that they do not have any kink or clots in those vessels. And then the inflow is usually an end-to-side anastomosis between the native aorta and the superior mesenteric artery of the graft. This is an example of the back table after the vessels have been cleaned up. We're looking from the back side, so the superior mesenteric artery is here, the portal vein is here. When we implant it, we'll actually flip it over so that the superior mesenteric artery goes down to the aorta and the portal vein, or SMV, goes over to the IVC. This is the proximal jejunum, and this is the distal ileum. After implantation, you can see a nice pink mobile small bowel that looks the same as a native small bowel. And here you can see the anastomosis between the donor small bowel and the remnant colon. The field of intestinal rehab surgery is difficult. It is some of the most difficult surgery that we can do as transplant and non-transplant surgeons, and requires persistence, patience, practice, and determination in order to have good outcomes. We know that transplant does not have ideal long-term survival, so we reserve transplant for those patients who cannot benefit from non-transplant surgery. However, it is a better option than nothing in patients with life-threatening complications, and the results have definitely improved over time. The type of graft does make a difference, and it does appear that the multivisceral transplants in the most recent report still lag behind either isolated small bowel, combined liver small bowel, or the modified multivisceral, where the liver is not part of the graft. In pediatric patients, isolated small bowel does appear to have long-term improved survival compared to all of the other types of graft, but reasonably close to remaining on TPN, as what I had shown in some of the more recent publications of parenteral nutrition. Our actuarial graft survival over time is fairly stable, with 75% at 1 year and more than 50% at 5 years. And of course, in pediatric patients, there is some indication that improved survival has occurred over the last decade. So this is just a memory of a time that my children were small, and we traveled to Colorado. They are now 21 and 23, and college graduate here and soon to be graduate here. And I'm very proud of them. But in summary, we have the, I think, mandate to do multidisciplinary management of patients with intestinal failure. And this should include not only gastroenterology and nutrition, but surgical disciplines. The evaluation needs to document the remnant length of small bowel, the function and the caliber and anatomy. It needs to look at what complications are experienced and what comorbidities are present to determine risks. And then when patients have life-threatening complications or low level of comorbidities or things that do not respond to medical therapy in terms of complications, we should definitely consider surgical options. We didn't talk at length today about fistula closure and ostomy reversal, but these are probably the most common scenarios for non-transplant surgery. The more innovative lengthening procedures should be performed by those who perform these surgeries regularly, as there is some nuance to getting good outcomes. And then, of course, transplant surgeries are beneficial to those patients with potentially life-threatening complications and can provide long-term survival and should be considered in appropriate patients. I thank you very much for your attention and look forward to any questions you might have. Thank you.